I'm Dr. John Roberts, and today we're going to talk about a CT-guided, flapless, immediate load implant surgery, where on the day of surgery we'll load the patient with a hybrid metal acrylic bridge. We'll be doing this today with the help of the team at Smart Implants. And first we'll start with what is the process of taking this edentulous patient and giving them implants and a bridge in a flapless guided situation on the day of surgery, all in one day. Well, to quickly go through the process, first we start with a good denture. The denture is important because the denture is the blueprint for our final bridge. We need it to be aesthetically and functionally and phonetically correct, as this will be copied in the final acrylic metal hybrid bridge. So if we have a good functioning denture and the fit is good as well, meaning that the integumental surface or the tissue side of the denture fits well to the patient, then that's the information we need to go on with our process. The integumental surface needs to be good, or meaning you have to have a new reline or new denture in this case, because the CT scan is going to pick up this information in the scan, and that is what we're going to make our master model out of, which all of our information will continue from. So once we have a good denture that's fitting properly, we can copy that denture with barium sulfate. The barium sulfate is a radio-opaque material that's picked up on the CT scan. Once we take the CT scan, this information then is, the DICOM information that's created from this, is then converted into a software. In our example today, we're going to be using Implant software. And in that Implant software is where we'll be able to do our virtual planning. And in the virtual plan, that's where we'll take our implants and place them and maximize the use of our implants as far as being able to get the biggest possible implants we can in the safest possible place, avoiding the sinus, avoiding nerves, and picking the densest bone we possibly can. So once we have this, we're able to use this information to then create our surgical guide and our final bridge. And the bridge that we're going to be using is going to be then transferred into the patient's mouth and held into the proper three-dimensional orientation according to where the implants are with something called the bridge carrier. The bridge carrier holds the bridge in its proper three-dimensional position while the patient bites down into the bridge and allows us to attach the bridge to the implants. So let me elaborate now on this process. To summarize, the process that we're about to elaborate on would be you start with a good denture, you turn it into a scan denture, you scan the patient, plan the case in a virtual environment, then you receive from the lab a surgical guide and the bridge, which is supported by a bridge carrier, and you place both the implants and the bridge into the patient's mouth. So the process starts with the denture, turning it into the barium sulfate denture. This barium sulfate is the radio-opaque material that we talked about that is seen on the X-ray. The advantages to this is that we now know exactly the position of the occlusion and the teeth and the bridge in relation to where the bone is in the patient's mouth, so that we can take that DICOM data set that's created by the CT scan while the patient's wearing the scan denture, the white denture you just saw in the last slide, and that now creates this Implant image where we can place our holding pins, we can place our implants, and we learn a lot about the case. We can see the bone, we can see how thick the tissue is, how deep do the implants need to be placed, where is the nerve, where is the sinus, and where is the soft bone, the dense bone. We also know where the occlusion is for the patient, and we know what kind of a restorative space that we need to plan for the patient and coming up into their bridge. And we do all of this in the virtual environment, giving us an ideal final result that soon will transfer into the patient's mouth. Once the plan is where we like it and everything's in place, then we can create our master models from this implant data. With the master models, we now can take that, and on those master models we can create our bridge and we can create our surgical guides. Here you see the surgical guides on the articulator on our master model that was created from this implant file. These are color-coded for implant size and for information that is communicated from the planning phase to the surgical phase. They're also numbered and they're also clear. The numbers, of course, correspond to the information being translated, like bone density and nerve proximity, and the clearness is used to ensure a good solid fit into the patient's mouth. So then we use the same master models and we make the hybrid bridge, the metal acrylic bridge, that is held into place with the bridge carrier. The bridge carrier is the clear plastic piece that you see surrounding the bridge here, and that is actually removable from the bridge itself. They snap together like a bridge docking system, but when the two are together they appear like a denture and they fit in the patient's mouth like a denture with the proper occlusion and the proper fit up to the tissue. And so the bridge carrier carries the bridge into the patient's mouth in the three-dimensional orientation as it was planned in the Implant virtual environment. Once the bridge is attached to the implants after surgery, then the bridge is in its proper position and the bridge carriers are removed and discarded. So this leaves us in a situation where the final step would be, if the patient and the doctor chooses, then you could convert that patient into final porcelain restorations. So the guided flapless immediate load dentistry. To get into even more detail, we're going to talk about mostly edentulous. Can it be done with partial dentures or immediate situations? Yes, it can. However, it's questionable whether it's cost effective in the partially edentulous, although I think that's quickly changing. And the immediate load, the problems that we run into is simply the unpredictability of how is the bone and how is the tissue going to heal. So on surgery day, sure, we can have it pre-planned, but how deep do we place the implants? Where is the bone actually going to heal, and where is that tissue going to close and heal to? Do we have the bridge placed in a final position that touches the tissue to ensure that we don't get speech problems with air under the bridge? So we're going to stick to, for this discussion, we're going to stick to a fully edentulous case. So let's start with the treatment planning. The treatment planning typically starts with nothing more than a pano. The pano is very valuable to us because at this point we don't know whether or not it's worth it to subject the patient to a CT scan, both for cost and for radiation, and usually we have a pano. And the pano combined with clinical knowledge and experience, we can have a pretty good idea as to whether the patient is a candidate for the implants in the fixed bridge and whether or not we're going to need bone grafting. And although we don't know for certain until we get the CT scan, we can have a pretty good idea. If we feel like the patient is a candidate, then before the CT scan, we need to have that ideal denture that we talked about. And so you would need to go through any steps that you had that you are comfortable with as far as making your final denture to create the most ideal aesthetic and functional and phonetic situation. Personally, in my practice, if I have a patient who has a denture that's close but may need some mild aesthetic changes, then I'll do an actual aesthetic mock-up in the patient's mouth, maybe increasing the incisal edge or changing the buccal corridor on that denture itself, and then taking an impression in the denture for a new fresh reline so that we have that perfect intaglio surface. If it's too far off, if our vertical dimension is too closed over the years and we don't have enough restorative space, or if aesthetically the patient's very unpleased with their current denture or the denture's just simply too old, then we need to start over and make a new denture. Once we have that ideal denture, we're going to convert that into the radio-opaque denture. And this denture sitting on the patient's ridge. The space between the bone and the bottom of the denture, of course, represents the tissue thickness. And this is important because this helps us determine what hardware is needed to build up underneath the bridge. Coming off of the implant, we're going to use a multi-base or a multi-unit abutment that allows us to have high divergence and still seat the bridge with draw. So we know how thick the tissue is and where we're going to place this implant according to all the information that we've already gone over in some depth on how to do the planning, preoperative planning for the patient. Until this point, all the information has been pre-surgical day, and yet we've gathered enough information that the next step is to receive the work that has been completed in the lab. And so now, once we get our information back from the lab, we're going to want to schedule one more quick appointment, which is going to be our pre-op try-in appointment before surgical day. The pre-op try-in appointment is very important because it allows us to check our work to this point. Because the bridge carrier and the bridge docking system can be worn as a denture, we can try this in the patient's mouth and look at the fit. See how it fits the tissue and see how it fits in the occlusion. If the occlusion is right on, it'll be obvious, just like a good fitting denture. If it's way off, then we know that we've made a mistake somewhere in one of our bite registrations early in our denture planning, or possibly in our conversion of our denture into a radiopaque denture. We also can try in the surgical guides and make sure that they fit well and that we're getting good tissue blanching in the patient. This can be a very quick appointment and save us a ton of time before we schedule that surgery day, which really should be a 2 to 3 hour appointment for both the surgery and the placing of the bridge. So here we have the patient biting down into the denture. There's a slight give in the denture so that the occlusion balances as the patient squeezes down into it, and we're looking for that bleaching in the clear carrier. Here's a video showing the process of the pre-op try-in appointment. We want to take the surgical guide that is numbered and color-coded and corresponding to a sheet of information that's delivered with the case from the lab, and we're going to try this into the patient's mouth. We're looking for that fit that would be solid like a denture, and we're looking for the blanching of the tissue through the clear guide. We also are going to try in the bridge and the bridge carrier on this appointment. The bridge and the bridge carrier can be separated into two parts. Together they work as a denture, and separated, of course, they're two separate pieces. On the right you can see the bridge that has been separated, and you can see where it has its metal support, which reaches in similar to a mesh in a partial denture. And on the left you can see the bridge separated from the bridge carrier, and you can see the holes in the bridge which have been positioned according to the plan in the Implant surgical virtual environment. So we're going to try this in just like a denture, and we're going to feel for stability, and we're going to have the patient bite into it. We want to make sure that the occlusion is right on. You'll also see a little give in between the bridge and the bridge carrier. That means that when the patient bites down into this, when we're attaching it to the implants, which you'll see in a minute on how we do that, that the fit is ideal and the occlusion is balanced. That bite there that you just saw was against another smart bridge that had been placed earlier. So once this is established, we're ready for surgery day. We know that the fit is good, we know that the denture fits, we know that the surgical guide fits, and so we have brought the patient in and we've numbed the patient up, and our first step is to remove the tissue tags where the implants are going to go and where we're going to form our osteotomies. So we're going to take a tissue punch and we're going to place the surgical guide into the patient's mouth without attaching it. We have not placed our fixation screws yet. And we're going to take on very low speed so that we don't overheat the tissue, and we're going to mark the tissue through the surgical guide, which then the surgical guide can be easily removed because of course we haven't fixed it with fixation screws, and we can make these cuts deeper and all the way down to the bone so that we can then pull that tissue out. Sometimes we'll use a trephine because it nicely grabs that tissue and just peels it back off the bone. Or you can use a periosteal elevator or even a scalpel and remove that tissue tag. It's important to remove these tissue tags because we don't want to pull any tissue up into our osteotomies, and as that can cause an infection and, of course, the loss of the implant. So now we'll talk about flapless and whether or not flapless is a good idea. On the right side of the screen, you'll see a video of us removing the tissue tags and how that's done. On the left, we have the data on whether or not flapless is a viable method for placing implants. I think it's accepted in dentistry now for some very good reasons. Of course, less pain is very important, and the fact that the patient has to take less pain tabs and heals in a faster period of time. We also show that it's a very predictable procedure. We have plenty of patients in the data that shows a high success rate, varying from actually fairly low at 74, but all the way up to as high as 100% in the year 2000 on flapless procedures. I think most importantly, however, though, is the fact that it minimizes the bone loss. You reduce the inflammation when you don't have to lay that full flap. And with a success rate nearing the same, or not even nearing, but as the same as other implants, that becomes a very valid way to do the surgery, being flapless. The immediate load and flapless is also documented as being a valid way to do these surgeries. Precautions can be taken at the same time. For example, internally irrigated drills or cooling your saline in the refrigerator until immediately prior to surgical use. So now we're ready to actually place the surgical guide in the patient's mouth. We're going to be using a little pilot drill here to be placing the 1.5 millimeter diameter fixation screw in the patient's mouth, and this will fit through the titanium guide hole in the surgical guide itself, and mostly we just want to poke through the cortical plate, as the screw is so narrow at 1.5 that it doesn't get a lot of bite into the bone tissue. So as we tighten it down, we don't want to over tight and strip the bone. We just want to tighten it down until it's secure, and then we'll place at least 3 of these so that we get a nice tripoded, secure fixation of the surgical guide. You'll see 4, sometimes 5 of these holes placed in the surgical guide in case we need an extra one. If we end up stripping one of the positions, we have extra positions to go to. So now we're ready to prepare the osteotomies. During the preparation of the osteotomies, we have a series of drill guide keys that fit into the surgical guide, each one at a different size. So we would start with a 2, which you can see on the far left, and that fits down, and that's going to be externally irrigated with the saline while we go down to depth, and we come across all the way to the final size that we need before placing the implant. And so as we step through these, obviously the direction is decided by the colored tubes in the surgical guide. As far as the direction goes, that's predetermined. However, the depth is also determined by where the colored tubes are placed within the surgical guide limits the depth and the final preparation of the osteotomy, so that if it comes right up on a sinus or above a nerve, that you're still safe to go to full depth on that drill. And this has to do with the fact that we know that the implant itself is, let's say in this case, a 10 millimeter implant. We know that the tissue is 3.78 millimeters deep, and we know where we place the tube, and we know how thick our key is, that is the drill guide. And if we add all this up and we do our math, we know that the tube is placed correctly, that we can go all the way to the hub. And this eliminates having to use a drill stop, like you see here, where that would have to be cut for each one.